1, on drug prevention. And beginning this month of November through February, we will be looking at specific initiatives available to us through the international organization partners. We will also explore new activities or policies that we can initiate. In January and February, we will have the full menu of activities available for review, and we will invite you to express your interest to the international organizations managing the respective initiatives. I have a few other administrative announcements. Please update your screen name so it lists your name, your organization, and your country. And thank you also for your feedback regarding the number of calendar invites. We recognize that we've been sending many calendar invites over the past month, 1 per hour of meetings. So for future meetings, we will be sending just 1 calendar invite for the entire block of 3-hour meetings of 3.1 to 3.3. And if you signed up for the supply or data sub-working groups, we'll also send you 1 single 4-hour block. And we will still send you a block for both East and West groups. So you would be able to choose whichever time is most convenient for you. We're also continuing to seek to increase coalition participation to include stakeholders from all target audiences of synthetic drug issues. So for example, if we're talking about prevention, it could be ministries of education, of health, of social development, of women. So please make sure that you invite other representatives from your governments to attend so that we can make sure that all stakeholders have a seat at the table. I also want to inform that the coalition website has launched. You can find it at globalcoalition.us. I'm going to ask Bill McLean from our team to post the website address in the chat and also today's agenda. And I will just very quickly show you here today's agenda. We have, I'm going to turn it over to our co-chairs for their opening remarks. And then we have presentations from UNODC on the CHAMPS program, from Dr. Joe of Colombo Plan on the Universal Prevention Curriculum, from ASEC Dexter of the Philippines on community-based prevention. And then we'll have a community-based prevention presentation from Charles University, Professor Gabrhelik. And then we'll have CADCA, Icelandic model, and communities that care as examples of community-based prevention. So we have a full agenda today. We want to just turn it over to our co-chairs. I'd like to turn it over to Maria Corazon Dumlao. Dr. Dumlao is the Chief Health Program Officer from the School of Health Division of the Philippines, and Ivana Teresin, the Director General Human Resources and Administration for the Ministry of Health of the Seychelles. I will turn it over to them to give their brief introductions and start us off and moderate the session following that. Thank you all so much. Bye-bye.
Thank you very much, Brian. And of course, thank you, Bill, for this very exciting session again for the Global Coalition. We will be full with the different topics and country presentations from our member government agencies and other non-government agencies. It's an exciting day. So I'm also asking my colleague, my co-chair, Ivana, to say a few words. Ivana.
Thank you, Maria. Thank you, Brian. So welcome again, everyone, for our second meeting. So I sincerely hope it be a very fruitful one, where we will try out most to pitch an idea so that we move forward in the area of prevention. So thank you, and over to you, Maria.
Thank you, Ivana. So let's brace ourselves for this morning and listen to the best practices of our invited high officials and guests for this morning, evening, and afternoon discussing about prevention. So we'll start with the presentations. Of course, we have here again our UNODC official, Wadih Maalouf, to discuss about the Children Amplified Prevention Services. Henki, we're losing the audio.
My name is Wadih Maalouf.
Do you still lose the audio?
It appears the audio is not coming through right now. No. The video is playing, but the audio is not.
How is it now?
Still no audio.
No audio, Henki.
No audio. Hold on a second. I could hear audio here. Let me figure out what's wrong with it.
You can kind of hear him really deep in the background. Maybe it's the volume issue.
So to start with the review of the purchases, the first component, what it is, you know that
Starting to come in. Probably needs to be a little louder.
effective
Needs to be louder.
prevention.
Yes, thank you.
Effective,
Let me start a little bit.
And we don't need to start the video over. The most important part is to play the presenter coming in. There we go.
in place covering different age groups, covering different levels of risks and beyond. But we know for a fact if we really want an effective response, that's
We
not
can hear it. It could be a little louder though.
Yes, the audio's not coming through now. Henki, there's still no audio.
the standard under the third chapter, the prevention standard for those who don't know is
How is it now?
WHO International Standards on Drug Use Prevention.
I think we have the audio already. We can start playing it again, Henki.
Sorry, can you repeat again, please?
I think we have the audio already, but you
Okay.
have to start from the beginning.
Okay, well, let me rewind it.
The 10 minutes that I have is an actual initiative that we are
Is it good now?
and be part of, which is checks.
Yes.
Yes, Henki.
To start with the review of the prevention system, the first component, what it is, we know for a fact that when it comes to implementing effective systems of prevention, to have an effective, coordination of different activities, the core ingredient is adding several evidence-based programs and policies in place covering different age groups, covering different levels of risks and beyond. But we know for a fact if we really want an effective response, that's not enough. Adding more and more interventions that cover different ages and different risk groups also requires a supportive system, kind of an umbrella of a mechanism that embraces these policies and put them in place and these interventions that actually can amplify or actually dilute the effect of these evidence-based interventions. So mapping out not only the interventions, but also this delivery system of these interventions is a key component for having a system that's in place that's effective. And this is exactly why in the prevention standard under the third chapter, the prevention standard for those who don't know is UNODC, WHO International Standards on Drug Use Prevention. There's a specific chapter dedicated to understanding the value of what is a system of prevention beyond just intervention, how things cooperate and collaborate together in order to have a system now. And this is where, in terms, there was a lack of a tool to actually even though I'm going to use the word in a different way, systematize the way prevention intervention are being mapped out at the local level, meaning at the national level, and being mapped out together in terms of how to move from where we are to another level and how to bring them together, not only at the level of intervention, but at the level of terms of how the umbrella that is embracing these interventions is functioning together. And this is where the review of the prevention system came in place. In a way, this is a way of assessing, mapping out all the different sort of interventions that are covered under the prevention response, prevention of drug use in these circumstances that we're discussing, and mapping them out and arbitrating their content against what the prevention standards, the UNODC WHO prevention standard mentions, in the sense of where are they in terms of the evidence that is portrayed in the standard, whether they are evidence-based packages in terms of design and application documented at the local level as evidence-based packages, whether they are important evidence-based packages adapted to the local context, but not necessarily evaluated in the local context where they are implemented, whether they are evidence-informed, meaning that they have been designed locally, but not necessarily tested, but they have the qualification of what makes an effective intervention, or whether they are far from the intervention standards, whether they are supportive services. So they map out all the different services, and this is where we see the color coding that you have in this slide, whether it's on the red side, on the yellow side, weakly informed, strongly evidence-informed, or evidence-based strategy, or supportive services. So this can be mapped out for every specific intervention. But that's not where it ends up in terms of decision-making processes tree, but also these interventions can be further against another matrix that maps out these services with their color codes across different ages of development, and within these ages of development, whether these interventions are at the universal level, at the selective level, meaning that for the population that are higher risk than the normal population, at the indicated level, whether they are interventions that are portraying evidence that is that are for a subpopulation that is symptomatic and need to be an intervention to address it before it escalates to something more. That is the horizontal way of seeing the mapping out of these interventions. But also vertically, you can see in which social setting these interventions are, maybe in the school, in the family, in the media, community, and beyond. So this is another way to flesh out whatever exists at the national level in a way to identify gaps and strength at the same time in terms of intervention, so that the decision-making is being done in a way that is informed by arbitrated by the standard and informed by local data that exists at the national level. This program, that is this strategy, which is the review of the prevention system, has been first piloted. Actually, the whole system has been done with the support of Norway, but it was also implemented in Norway. We would have wished that Norway could have joined to actually demonstrate and talk about their experiences in the Ministry of Health in that case, in terms of implementation of the prevention standards, the review of the prevention system. But even in the absence of Norway speaking directly with regard to the content of this document, the presentation itself has two web stories reflecting on the experience of the Norway vis-a-vis this document that fleshes out and describes in more details their experience and how it helped their decision-making processes. Between brackets, recognizing as well my colleague Giovanna, who's the chief of section, who has been a key person in terms of working hand in hand with the national authority in Norway and the course group in terms of actually not only collecting the prevention interventions that are there, but also arbitrating manually, intervention by intervention, where these interventions fall within these processes. Now, with this experience generated in Norway, with this new tool of REPS, this has been a tool that for us as UNODC is a strategically important tool that fill an important gap in the prevention basic element moving forward, where national strategies that are developed for a long period of time have been really based on epidemiological studies, but the SWOT analysis, when it comes to actually addressing the strength, weakness, opportunity, and ability services that are existing nationally, have not been arbitrated by a really sort of proper system of evaluating where the intervention is of the response and what the gaps are. Also, it is a tool that really identified, very systematically intervention and responses that previously have not been accounted for as part of the national strategies, by moving with the policymakers in the perspective of digging in for interventions that are in line with the prevention strategy, because the policymakers are always fixated on responses that are articulating the word drugs in them and talking about drugs. And this developmental approach, where there are other strategies that not necessarily the intervention of the strategy discuss drugs, but are in line with the standards, are mapped out within the system to capitalize on them and the prevention responses. So it orients national plans of action that would inform decision-making processes rather than just guesswork when it comes to the previous SWOT analysis. It also helped them in terms of efficient investment in resources and priority to articulate the national responses, whether I'm going to invest in further scale up of this intervention, reduce the investment of this intervention that's not evidence-based, increase in investment in this supportive intervention, improve on research and development of the third intervention to move forward and allocate my resources that are designed for prevention in an appropriate way. It advocates for streamlining and coordination responses through this mapping of services, but more importantly, through doing this, it advocates for improving the quality of the prevention delivery, a component that is linked with additional tools that will be talked on with other interventions coming up during the day. But that's a way of understanding the value of having the quality of prevention and promote the value of monitoring and evaluation of prevention interventions. A component of this review of the prevention system as well is assessing how the coordination is happening, the level of coordination, the legislation, not only looking at the level of interventions. So this is item number one that needed to be presented with regard to a new tool that hopefully member states will benefit from with regards to being a building block to the prevention response. The second component is that initiative that we are putting in place. With this mapping of new tool that's being developed, CHAMPS, which is the Children Amplified Prevention System service, is a modality that UNODC is inviting member states to really have models globally of investing in prevention at large scale through this developmental approach, mapping out the services that they have at different ages of development for different level of risk, with a level of mechanism of bridging the different partners of the response together, and showcasing within a period of 5 years that demonstrating that a change in the developmental pathway, including, of course, as a priority for the age group that is using, that could move to the age of using drugs. We're talking about children, 0 to 18. Then later ages that prevention of drug use is put in place because of this investment, and at earlier ages, other indicators of that are on the developmental pathway of at the mediating level of prevention, like improved educational attainment, retention in school, improved mental health, reduction in violence against children, and beyond, can be demonstrated to this level of investment. This is in a nutshell, how the system is being put in place as a descriptive model, where first it will start with a review of the prevention system, what exists and what needs to be improved, put forward. Parallel, this is the horizontal line. Vertically, there will be, as usual, this evaluation of the epidemiologic situation, of the situation that needs to be addressed in terms of priority work, through which the children that we're talking about from 0 to 18 will be allocated through universal, selective, that's in the universal in green, selective in yellow, and indicated at the level of the red line, symptomatic children, would receive a minimum amount of packages to different ages of development, brought together. All of these interventions over a period of 5 years, put to scale, will have model implementation of different countries.
Sir, I'm very sorry to interrupt you. Interpreters are saying that we are too fast. Can you please slow down for interpretation? Thank you.
I wish I had this message earlier. Sorry, I still have one more slide, but I will slow down for the rest. So it's the challenges of doing it in 10 minutes. So this level of intervention, different ages of development, from pregnancy and early infancy, up to 6 years, which is the period before going to school, 6 to 10 years, the early school years, 11 to 14, early adolescent years, and beyond, would all have a minimum set of skills, of packages that are social and emotional skills, or environmental strategies that are in line with the prevention standards, and demonstrating that this level of investment will showcase effectiveness, will showcase cost effectiveness, and will showcase a high return on investment in preventing drug use and beyond, supporting other strategies. So what we're looking for is, at least in different waves, 10 countries per wave over a period of 5 years. And this first wave of countries, we are hoping that will be launched by CND, our Commission on Narcotic Drugs 2024, which is coincidentally be during a midterm review period of implementation.
Wadih,
Yes.
tenemos el tiempo.
We are in time now.
Yeah.
Your presentation is super interesting.
Yes, exactly. And that's I want to present. No, thank you, Karina. I was just wrapping up and finishing. That was my last slide. And that's the CHAMPS initiative. And over back to you.
Okay.
Thank you very much, Wadih, for again walking us through the different settings in the UNODC standards for us to better appreciate the need for evidence-informed programs and policies on prevention, contextualizing the different settings. We also took note of the health-centered drug control system and the need for a strong infrastructure system. And this is really critical in our designing of our strategies. We also had a better appreciation of the gaps and the opportunities to fill on these gaps by supporting national strategies and global as well as local partnerships. Again, congratulations to USINL for this laudable initiative. Noted on the Children Amplified Prevention Services, which is, I believe everybody agree that this is something worth investing on. On the prevention systems tools for the school-based monitoring and evaluation, we also appreciate this new information. And for the second presenter, we will be joined by Dr. Choong to discuss about capacity building initiatives, particularly for the Universal Prevention Curriculum and Advocacy. Let's welcome Dr. Choong of the Colombo Plan.
No audio yet.
No audio yet.
Maria, did you say no audio?
Yes, no audio yet, NP.
That's interesting. Okay, let me try again. Because I haven't changed any settings. Everything was the same as the first one. Let's see. Is this good?
No audio yet.
That's interesting because I heard audio here and I see my audio is going out. My apology about it. Let me try again.
In my screen, it says here original sound for musicians off.
Yes.
I see a comment in the chat in the share tab to click the share audio button.
Say again.
In the chat, somebody said in the share tab, there's a share audio button. Maybe that might help.
Audio is shared and my setting is exactly as the first one, the first video. So let me double check everything because as far as I could see, everything is okay. My apology. Let me try again. My original audio is on, the sound for musicians, everything is on. No echo cancellation, stereo audio, high fidelity music video. Okay, let's try again. Okay.
Substance use disorders contribute significantly.
How is it?
It's okay. It's working already.
We hear it with an echo, but we hear it.
The prevention of substance.
I'm sorry, I couldn't hear you. My audio here is super loud. Could
Yes,
you
we
hear
can,
the audio?
we can hear it.
Yes,
There's a bit of an echo,
yes,
but we can hear it.
Okay, let's do it.
Use and other such problems is a goal that can significantly improve the health and well-being of people around the world. Cognizant of this, with funding support from INL, US Department of State, the Universal Prevention Curriculum for Substance Use series was developed in 2013 to disseminate evidence-based prevention knowledge and skills to prevention practitioners around the world, working in a range of settings to reach all populations, with research-based strategies developed to strengthen families, schools, community, organizations, and other institutions. It consists of 2 training series, UPC coordinators and UPC implementers. In April 2020, they were changed to UPC managers and supervisors and UPC practitioners, respectively. The UPC for managers and supervisors consists of 9 courses that are designed to assist people working in government or non-governmental organizations to oversee programming and policies in substance use prevention. The UPC for Practitioner series, which consists of the core course and 7 specialty tracks, provides an overview of prevention science as it is applied to the real world of interventions and policies at the grassroots community level. The core course provides an introduction and overview of prevention science and is required as a prerequisite for participation in the specialty tracks. Upon completion of the pilots and post-pilot revisions of the UPC for managers and supervisors in 2014, this training series was disseminated to prevention professionals in Asia and Africa the following year. To date, a total of 54 DDR professionals have undergone the entire managers and supervisors series, that is, 18 from Bhutan, 20 from Malaysia, and 16 from the Philippines. Similarly, after the piloting and post-pilot revisions of the practitioner series, the core course and selected specialty tracks were disseminated in Asia, Africa, and Latin America, starting from 2018. To date, a total of 409 DGR professionals have been trained on one or more courses of the 2 training series in English or Spanish. In July 2020, when the COVID-19 pandemic hit the world, the Colombo planned a drug advisory program with additional support from INL in terms of funding, embarked on the transformation of the universal curricula into an online instructor-led version in both English and Spanish that included, among others, the 9 courses of the Managers and Supervisors training series and the core course of the practitioners. These are the universities and other tertiary institutions contracted to develop the 9 managers and supervisors. To date, a total of 499 DGR practitioners from Asia, Africa, and Latin America have so far successfully completed the piloting of the English or Spanish version of these 10 online instructor-led courses, or the revised core course, or the revised courses 1, 2, and 3 of the Managers and Supervisors series in either the English or Spanish version. These online courses maintain the same contents as that of the original face-to-face version. The difference lies in the delivery of the contents that have been adapted to the online format, thus seeking to maximize the opportunities provided using online technologies. In short, we complement and supplement the face-to-face version. Let's hear what the learners have to say about their learning experience with the online instructor-led courses. According to them, online courses require good time management, the ability to juggle time between personal and family life, work commitments, and the online course itself. Collaborative work with co-learners, amongst other things. For trainer reflections, we will share with you the recording of Lane Labrador, the instructional designer and instructor for the online course.
My experience in creating and handling the online UPC core course has been both fulfilling and exciting. The UPC core course was originally designed for face-to-face training. So when we converted it to its online version with self-paced learning components, we had to consider principles of adult learning, planning different activities that will engage the learners while learning the course contents, and staying faithful to the key components of the UPC core, and at the same time, helping our learners connect and apply what they learned in their own professions. As an instructor of the course, it was fulfilling to facilitate the sessions and helping the learners during the course until they complete it. Sometimes it could be challenging to check all the outputs and give timely feedback to the learners. But with proper time management and follow-through, handling the course is manageable given the appropriately spaced schedule in the agenda. Overall, I believe the online UPC core course is a wonderful training opportunity that has the potential to meet the individual needs of the learners from all over the globe with its flexible design.
Thank you, Lee, for sharing your insights with us. If you are wondering what is in the pipeline for trained prevention professionals, the good news is that the ICAC prevention will soon be available after having undergone piloting in 2022 and revised accordingly. This is your time to be among the counted few prevention professionals in the region and beyond to be trained on the in-person or online instructor-led versions of the UPC Managers and Supervisors and or Practitioners training series. We are here to help you achieve your goal. Write to us for further information. Thank you.
The Colombo Plan Drug Advisory Program. Changing lives for the better.
Thank you very much, Dr. Joe, for walking us through the journey on the Universal Prevention Curriculum since 2013. And that was the time when you started the 9 courses for the UPC Manager Series, and then followed by the UPC Practitioners, and then the Specialty Track, and then the core course. It was initially offered in Asia and Africa, and we're so privileged with Ivana for being able to be part of this capacity building initiative of USINL and Colombo Plan. We also appreciate the journey when we went through the different transformation of UPC Managers and Supervisors series through instructional videos. And we are inspired actually to take note that soon the credentialing will happen next year for prevention. And the 499 DDR UPC trainers and practitioners, this is really a strong force to start with. Thank you very much again, Dr. Joe, for such an inspiring presentation and getting us appreciate the journey for prevention. So we will now listen to the next presenter. For the Philippines, we have the Assistant Secretary for Operations of the Department of Education, Philippines. Let's now welcome ASEC, Dexter Galban.
And Dr. Dexter Galban, Assistant Secretary for Operations of the Department of Education in the Philippines. And today I hope to share with you our experience in the department when it comes to professionalizing the preventive workforce, particularly when it comes to training and certification. And to briefly share with you our game plan, we established several partnerships with different institutions that advocate for drug abuse prevention education. And of course, that includes USINL, among many others. The Colombo Plan serves as one of our major partners in ensuring that we're able to deliver the necessary interventions for our students and our learners. And as such, building on these partnerships, we intended and we hope to continue training our trainers, our TOTs, conducting our regional rollout, and of course, upskilling our capacity for credentialing to ensure that eventually all critical health personnel and non-teaching personnel that are involved in drug abuse prevention education will have the proper training and credentials in order to effectively protect our learners and help build a better future for them. And hopefully all of these will contribute to us strengthening our campaigns to reduce the demand for all of these potentially dangerous endeavors that our young people may be exposed to, and ultimately strengthen demand reduction programs within the Philippine context. So in terms of our National Training of Trainers, or NTOT, we first conducted our core courses in November 2022, held in Makati City, and this was subsequently followed by the second phase, conducted in Cebu City in March 2023. This eventually culminated with our UPC course 5, which is focusing on school-based prevention in May 2023, held in Bacolod City, eventually us having 25 NTOT completed, which serves as our fundamental base in ensuring that we would be able to roll out the program effectively. Then, of course, this translates to our regional rollout, from training of trainers to the eventual rollout within our specific clusters. First of which was the Luzon cluster, held in October 2023, followed by our Visayas cluster in the same month, just at a later date. And hopefully, by the first quarter of 2024, we will be able to complete our tri-area clustering of training, with the Mindanao cluster closing out the regional rollout. And of course, in terms of credentialing, we exerted effort to have our refresher courses and specialty track topics so that we will be able to upskill those that have undergone the program, specifically those from August 2023, and eventually the credentialing examination for our trained participants during the first quarter of 2024. And all of these things are aligned with our Matatag agenda, which is our resilience agenda. Bansang Makabata, Batang Makabansa, a country that is for the children, a child-friendly country that is intending to create patriotic youth, patriotic children for the Filipino people. And in terms of the breakdown of our Matatag agenda, that's making the curriculum relevant and produce competent, job-ready, active, and responsible citizens, taking steps to accelerate the delivery of peace education facilities and services, taking good care of learners, and giving support to teachers. And of course, for us, as part of this collaboration with the USINL, the Colombo Plan, and everyone else as part of this endeavor, we're focusing on taking good care of learners by promoting learner well-being, inclusive education, and a positive learning environment. So these are just snapshots of our experiences as part of the Department of Education Philippines in terms of professionalizing the prevention, workforce, training, and certification. Once again, I'm Dr. Dexter Galban, Assistant Secretary for Operations of DepEd. Thank you very much.
Thank you very much, ASEC Dex, for the very strong leadership and commitment to support the capacity building activities in partnership with the USINL and Colombo Plan. And we know that with your presence, the UPC journey will go a long way. So we move now to the next presentation, the community-based prevention by Professor Roman Gabrhelik of the Charles University.
Hello everyone. Today we embark on a short journey into the world of community-based prevention, unraveling the strategies and collaborative efforts that make our communities healthier and safer. This diagram illustrates the hierarchical structure that goes from individuals to society, with key intermediate levels such as social networks, organizations, and communities, influencing and connecting these different layers. There are dynamic interactions and influences across the continuum. Today, we focus on communities. So, what is community? In the context of substance use prevention, a community is a group of individuals living in a specific geographic area or sharing common interests or characteristics or concerns related to substance use and its impacts. It may consist of residents, local organizations, institutions, and stakeholders interested in promoting health and well-being while addressing substance-related issues. The concept of a community extends beyond mere geographical boundaries and encompasses shared values, social networks, and collaborative efforts to prevent substance misuse, support affected individuals, and create a supportive and resilient environment. Effective community-based prevention engages diverse community members, fosters partnerships, and implements targeted strategies tailored to the unique needs and dynamics of our target populations. Here are key strategies. Community mobilization. We need to engage community members, leaders, and organizations to actively participate in planning and implementing prevention efforts. Another is education and awareness programs. We need to raise awareness about the risks of substance use through education campaigns, target schools, workplaces, and community events. We use skill building programs to provide programs that enhance life skills, coping mechanisms, and resilience among community members, particularly in youth. We need to focus on policy development to advocate for and implement local policies that discourage substance, alcohol, and tobacco sales, and promote a healthy environment. Environmental prevention. We need to modify the physical and social environment to reduce opportunity to substance use, such as limiting access to alcohol or tobacco outlets. Parental and family programs are needed to offer and educate parents and families on effective communication, parenting skills, and creating supportive home environment. School-based prevention, also important. We need to implement evidence-based prevention programs within schools that foster and work on skill development, peer resistance, and foster a positive school culture. We need to empower community coalitions, form coalitions involving diverse community stakeholders to collectively address substance use issues and implement evidence-based interventions. What is important is to access the treatment and support. We need to ensure that culturally competent treatment options are accessible for individuals who struggle with substance use disorder, and also we need to support their families. Media literacy programs are necessary to develop and enhance media literacy skills among community members, empowering them to critically assess and resist media influences by promoting, that promote substance use. Community policing and enforcement. We need to collaborate with law enforcement to enforce policies related to substance use and ensure community safety. And evaluation and monitoring. We need to regularly assess the impact of prevention strategies using data to refine and improve ongoing efforts. Despite many advantages, these services are more costly, challenging to orchestrate, and are not easy to implement, sustain, or evaluate. However, community-based prevention services, if implemented effectively, are cost-saving, yield significant reductions in substance use within communities by combining multiple strategies involving various key players who are also knowledgeable of the community problems and needs. Of course, there are examples of programs in the community settings that are available and implemented in the real world. For example, communities that care, CADCA, the Icelandic model, Prosper, STAD. It is important to say that there are more examples that are evidence-based. I know that it was short, but I hope that it gave you at least a little bit of insight into what is community-based prevention. Thank you for your attention.
Thank you, Professor Roman, for sharing with us strategies to attain the goals of creating a supportive environment for community interventions and for sharing EBI programs and projects that works. So we now call on the next speaker from CADCA. We have the country testimonial from Eric Siervo and Dr. Raquel.
Hi, I'm Eric Siervo, and with me is Raquel Tolentino, and we're here today to talk to you about CADCA's model for community change, which is predicated on two overarching goals. Goal number one, increasing collaboration among groups and sectors in a community, and number two, reducing substance use among youth and over time adults. And community coalitions are the vehicle from which to accomplish this. Is formal collaboration among groups and sectors of a community. And we equip communities with what they need to know and what they need to do to be effective change agents through the three pillars of our model for community change. And for that, I'm going to hand it over to Raquel Tolentino from the Philippines to talk about their experience.
Thank you, Eric. ADA Philippines is the umbrella organization of all the 42 local coalitions trained by the Community Anti-Drug Coalition of America. The association works closely with CADCA
to promote the development of drug prevention infrastructure through the engagement of local government institutions and residents in the development of community coalitions in the Philippines. AADAC provides services that help address the needs of the local government units in the drafting of their anti-drug plan of action. They share the CADCA model, specifically strategic prevention process, the 7 strategies for community change, and encourage the multi-sectoral participation. Here is an example of one coalition who made use of the CADCA model to identify and address the drug problem in Keow, Barangay Banago, Bacolod City. After the conduct of community assessment, it has been confirmed that selling of methamphetamine was identified in the dark streets of Keow, and as a result of their proposal to the new government center of Bacolod, the mayor ordered for the installation of street lights on the said Purok to prevent drug deals in the area. Regular roving in the areas of the village guards has also become a practice, and curfew hours are now being observed. The coalition conducted drug prevention sessions in the residents of the said community, and due to the increase in awareness, the coalition together with the community work hand in hand to ensure that these areas will remain free from any drug-related activities. AADAC partners with the different national agencies in the country and have gained accreditation to the Philippine Drug Enforcement Agency and the Department of Interior and Local Government. They have been authorized to engage in the implementation of the Philippine Anti-Drug Strategy, who can work on policy formulation, advocacy programs, and drug demand reduction in all the regions in the Philippines. All coalitions were also encouraged to get accreditation with the local government units as civil society organization partners for drug demand reduction. The local government units can fund the community assessment, capacity building, strategic planning, program implementation, and monitoring. On capacity development, AADAC have organized 5 national conferences in partnership with CADCA. This is an annual event that gathers all coalition leaders for updating, learning, mentoring, and sharing of coalition success, issues, and challenges. This is an adaptation of CADCA's annual mid-year training that the AADAC finds very relevant in capacitating its members and enhancing the skills and knowledge of our coalition leaders. Thank you.
Thank you, Eric and Dr. Rachel, for that presentation on the CADCA's model for community changes, and of course for introducing the very strong infrastructure for multi-sectoral participation and sharing also with us strategies implemented at the grassroots level. We now call on the next presenter, the Icelandic model by Dr. Viðar Halldórsson for the country testimonial.
From all over the world. My name is Viðar Halldórsson. I'm a professor of sociology. I want to use this short presentation to highlight the importance of the social environment, in particular the local community, for the general well-being of individuals and groups. In the 1990s, Iceland had faced major problems in terms of adolescents, alcohol, and other substance use. At the time, Iceland had, for instance, the highest proportion of adolescents who had been drunk by the use of alcohol in the whole of Europe. However, with the forming of what is now known as the Icelandic prevention model, Iceland managed to reduce its problems of adolescent alcohol and the use of other substances from remarkable extent. In recent years, Iceland has had the lowest proportion of adolescents who have been drunk in the whole of Europe. This figure we see here illustrates the declining trends of alcohol use, cannabis use, and smoking in Iceland from 1998 to present. And the declining trends are a result of the efforts of people in the Icelandic communities to make the world a better and healthier place for its kids and adolescents. This remarkable success in preventing kids and adolescents from start to drink alcohol and other substances has been achieved by a widespread coalition between major community stakeholders in Iceland at the local level. It has, for instance, been important to strengthen the communication between schools, all kinds of leisure activities which kids and adolescents partake in, and their parents, of course, It can in return coordinate their actions in terms of how they can organize activities for the young and further communicate effectively to tackle problems which may arise among the young. It is further been highly effective as a prevention measure of youth substance use if parents know and are in contact with the children's parents' friends. Such social ties create communication among parents, a consensus on the rules and guidelines they wish to impose, and thus work as social control of the social environment in which the children's lives are embedded. It has also been highly effective as a prevention measure of youth substance use if kids and adolescents have opportunities to partake in healthy and challenging leisure activities in the local communities that are guided by adults. Such activities provide young people with important framework in their everyday lives, in which they need to invest and commit to, and which keeps them occupied with something healthy and meaningful rather than something else. Today, the Icelandic prevention model has become a system in its own terms. In other words, it has become mainstream norm, which is embedded into the Icelandic culture and its institution. The Icelandic prevention model is further being implemented in many parts of the world. We have evidence that the ideology which the Icelandic prevention model rests on can work in all the parts, as well as it does in Iceland.